Good afternoon, my name is Sarah Davis. I was the health economist on the guideline that Ratan has just been describing. I'm a senior lecturer in health economics at Sheffield University. And as Ratan said, the NICE guideline was commissioned to look at developing evidence-based recommendations to prevent perioperative hypothermia in the UK NHS, and it was published in 2008. And through the course of that guideline, we developed an economic model to assess the cost effectiveness of warming patients. The reason for doing that is that NICE is required to look at both clinical efficacy, and it's also required by its government mandate to look at best value for money for the NHS. So the principles for NICE decisions, they include not just cost effectiveness but clinical effectiveness, the extent of the uncertainty in those two factors, legal and policy constraints such as equality legislation, and also the practicalities of implementation within the NHS. So although cost is an important factor, it's not the only thing where the guideline group considered. But why should we worry about costs in the first place? Well, if we spend more money on one thing, we have to spend less money on something else. That's true at a government level, it's true at a hospital level, an insurance company level. Everyone has to decide what they're going to spend their money on, and they have to know whether it's going to actually be better spent in other ways. So economic evaluation is comparing alternative courses of action in terms of both their costs and their consequences. So you've got a new treatment and a current treatment. You want to look at the cost of applying that new treatment and also the consequences in terms of the health gains or possibly cost savings or additional costs that may result from that treatment. Within our model, we looked at 4 key warming strategies and compared these against strategy of usual care, which we defined as no fluid warming and no active warming. The strategies were forced air warming intraoperatively, warm fluids during surgery, and then a combination of both of those. We also looked at pre- and intraoperative forced air warming with warm fluids, and as I said, against usual care with no warming. We did also look at a few other strategies that came out of the evidence, but some of those were excluded from the main comparison because they weren't cost effective compared to one of these. So the full details are in the guideline. There was a lot of studies, a lot of different devices, a lot of different mechanisms, but these were the main ones that we focused in on our comparison between the different strategies. At the time we developed the model, we were aware of the indotherm patient warming system, but there weren't sufficient studies to include it within our model at that time. So what costs did we consider? Well, the main costs of warming are the equipment costs, reusables and disposables, and the consequences, which we've already had described to us this afternoon. So things like pressure ulcers, bleeding, extended PACU length of stay. So we need to look at the cost of those consequences and also any quality of life decrements that might apply to the patients as a result of those. So the cost of warming, the main costs for forced air warming and fluid warming are the disposable blankets and inserts. We looked at the range of costs across the UK from different manufacturers, and we used the average of those within our model. There's also costs associated with the purchase or hire and maintenance of equipment. Those were much smaller costs. We did include them, but they're a much smaller factor within the model. And what consequences did we include within the economic evaluation? Well, we looked at all the evidence, as Ratan said. It took us many months to go through all the evidence. It was quality rated, it was assessed in terms of the quantity, the consistency and things like that. And in the end, we decided to include 4 consequences within the main model. These were surgical site infection, morbid cardiac event, mechanical ventilation, hospital length of stay. Those figures give you a rough idea, 4-fold increases, approximately that. They're not the exact figures. We also looked at blood transfusion, pressure ulcers, and post-anaesthetic care unit length of stay. However, the evidence in those areas was less strong, and we decided to exclude them from the base case. When you're looking at cost effectiveness, you need to consider whether the answer is the same for all of your patients or whether it varies within the patients. So you may be able to find a group of patients in whom it is cost effective and another group of patients where it's not really worth it, and you want to be able to make different recommendations rather than saying yes or no to everybody. So the things that we looked at in the model were the baseline risk of hypothermia, which we varied according to the magnitude of surgery, anaesthesia type, duration of surgery, comorbidities. Those are the risk factors that Ratan described earlier. And also we looked at the risk of cardiac complications. Obviously that's a key factor in the model, and it's likely to vary according to the age of the patients. We also allowed the length of stay for unwarmed patients to vary according to the magnitude of surgery. And we also allowed the cost of infection to vary according to the magnitude of surgery, so that you had a greater consequence of an infection in a patient having major surgery compared to minor surgery. Okay, so this is a summary of the actual costs we applied in the model. So for each of these, the cost shown is what you avoid by preventing perioperative hypothermia. So for a surgical wound infection in minor surgery, around £950, and major surgery, it's nearer to £4,000. And then you can see morbid cardiac events, the cost of those are quite high. We also looked at a requirement for post-operative mechanical ventilation. Although the cost of this is very high, the incidence is very small, so that was a smaller factor within the model. And the length of stay we applied in the model is £275 per day. So that's all the costs that we put in. What about the health outcomes for the patients? So within health economics, we like to use generic tools to measure quality of life. The nice thing is these things can be applied across different disease areas. The two most commonly used ones of those are the short form 36 and the EQ5D. They might be measured in the patient trials, but quite often, even in large drug trials, they're not included. So we have to use data from other sources and apply those quality of life scores separately. So what is a QALY? The outcome that NICE prefers to use is a quality adjusted life year. It's 1 year of life for a healthy person. And the nice thing about QALYs is that you can trade them off between people and you can trade them off over different time periods. So one QALY is 2 years of life for a person who is 50% of full health. It is also equivalent to 6 months of life for 2 healthy people. So here is a representation of QALYs. You might have a current treatment, gives you a quality of life for a certain amount of time, and then you die. And a new treatment which gives you a similar quality of life for most of your life, but an extended survival. You can see here that you're gaining QALYs from that extended survival, but you're also losing some QALYs if you've got a side effect of that treatment. That might represent a cancer drug or something like that, where you've got an initial side effect. So as I said, the nice thing about QALYs is you can sum up, you can trade off things like survival versus quality of life if you've got an unpleasant treatment. You can look at the duration, frequency and symptoms in a chronic conditions. You can have a QALY profile over the whole lifetime. And you can also weigh up benefit versus harm. So if you've got a high-risk surgical procedure, you'll have a risk of mortality in a small minority of patients, and then you may have a quality of life or survival benefits in other patients. And what you want to know overall is this procedure going to improve people's QALYs overall. So it allows you to trade off risks and harm, benefits. And the nice thing, as I said, is it allows us to look at health gain on a population level and think about decisions nationally, so you can actually say, okay, are we increasing the net population of health by using this drug in this disease or this drug in this disease? So it's a nice kind of metric across all populations. So within our model, we only looked at QALYs for 2 of the outcomes. Those were surgical wound infection and morbid cardiac events. For surgical wound infection, we assumed a 7% decrement in quality of life over 1 year, so you get a QALY loss of 0.07. For morbid cardiac events, we assumed there was no long-term decrement from ischemia, i.e. that it was reversible and there would be no long-term effect. But for cardiac arrest and myocardial infarction, we applied a utility decrement every year for the remainder of that patient's life. So for young patients, you're applying that decrement every year for a long time. You may lose 5.5 QALYs over their lifetime. For an older patient, they have fewer years to live, so they may only lose 1.93 QALYs over their lifetime. For the other outcomes, we assumed there was no quality of life change. So how do you bring these two things together, the health benefits and the cost, to make a decision? So say you've got a usual treatment, that's your baseline. You might have a new treatment which is more expensive, but maybe you'll save some money from using it because you're improving patients' health, maybe their length of stay goes down. Hopefully your new treatment is more effective, so you're going to increase your QALYs, but it may also have some side effects, say if it's a cancer drug, some side effects will reduce your quality of life. And then you have several different options. One is that the new treatment is down in this lower right quadrant. That means it's got lower costs and it's more effective. Clearly you're going to recommend that. Then you have a treatment in the upper left quadrant. It's got higher costs, it's less effective. You're probably not going to recommend that. You might even recommend that people stop doing it and they go back to whatever the usual care is defined as. And then you've got this decision to make in between, how much you're willing to pay for your quality adjusted life year gained. If you've got high extra cost and low QALYs, then you're up in that point there. And if you've got low extra cost and high quality gain, then you've got a lower slope, the lower ISA. And you've got to decide where you're going to put your threshold, how much are you willing to pay for that extra quality. In the UK, we apply a threshold of £20,000 to £30,000 per quality. It's not a fixed threshold. The decision makers are allowed to apply the judgment about the quality of the evidence. They're also allowed to think about the uncertainty in the decision. But somewhere around £20,000 to £30,000 per quality is where we consider it becomes not cost effective. Okay, so treatments under that line are considered to be cost effective and may be recommended. So what are the results of from our model? Well, this is an example results. We looked at lots of different scenarios to take into account the different risk factors. So these are the results for a 50-year-old with no comorbidities, having minor surgery lasting 60 minutes. This is our central scenario. We thought that a good bunch of the patients are going to be like this. And the first row, you'll see that's the usual care arm. And the incidence of hypothermia in that arm is 237 per 1,000 patients. And then the cost consequences are 104,000 approximately. That's the consequences of your myocardial infarctions and surgical site infections. And the quality loss from those consequences are around 227 qualities lost. And the cost of that strategy is set to 0 because it's the one we're comparing against. And then the next row down, you'll see forced air warming intraoperatively, and the incidence of hypothermia in that group is 116. So you've lowered the incidence of hypothermia, which means your cost of the adverse consequences of hypothermia are lower, and your quality losses are lower, so you're gaining qualities in that case. But you've also got the cost of the strategy, the forced air warming blankets. So for 1,000 patients, that's £16,000 approximately. Now, if you look at the cost of the consequences, £87,000, and the cost of the strategy is £16,000, they're actually less than the cost of usual care. So in this case, we consider the strategy to dominate usual care. It costs less money, and it gives you additional benefits. If you go further down the table, the bottom row, you've got forced air warming pre- and intraoperatively, and you've also got warm fluids. Your incidence of hypothermia is much lower, 80 per 1,000 patients. Your costs of consequences are lower, your quality losses are lower, but your cost of the strategy is higher because we assumed that you would use a different blanket for pre- and intraoperative warming. In this case, you're paying an additional £2,000 for each quality that you've gained. So although it's no longer cost saving, it's still well below the UK threshold of £20,000 per quality. Okay, so to summarise what the guidelines' main results, in many of the scenarios we looked at, forced air warming or all warming strategies were cost saving compared to usual care. The prevention is more cost effective in patients at higher risk of hypothermia, for example, those having major surgery. It is also more cost effective in patients who have got higher risk of complications, such as those of a higher cardiac risk. We found that warming fluids was cost effective in all scenarios, and as Ratan said, we recommended that you warmed fluids if you were going to give them. We found that forced air warming was cost effective in all but the lowest risk populations. So we considered young patients, short procedures, who maybe had no risk factors. There may be some patients in whom it wouldn't be cost effective to warm. Okay, that's the majority of my talk. Here's some details on the guideline where you can find it. And also an update of our guideline is being scheduled into the NICE work programme. So they will go through the same process and they'll come out with a revised guideline. And as I mentioned earlier, we weren't able to assess the Inditherm patient mattress. But since we did our guideline, NICE have been able to do a technology appraisal on that, and they have published separate recommendations. Okay, thank you.